This is the 13th annual lecture, and we are pleased to have some students both virtually and also here, and they have always been very loyal attendees. At the inaugural Lambeth lecture, Joel Fleischman affirmed his gratitude to the Lambeth Lecture Committee for selecting him as the inaugural lecturer for one of North Carolina's and the nation's longtime leaders in public policy, politics, and philanthropy. He further observed that Tom Lambeth is a great and good human being who has passionately and unstintingly, but always intelligently and with the greatest of good cheer, devoted his life and is still devoting his life to serving the public good. We remain grateful to the Lambeth Lecture Committee, many of whom are here today, as well as the faculty of the College of Arts and Sciences Department of Public Policy, including its chair, Dan Gitterman. Both as Dean of the College of Arts and Sciences and more recently as our 12th Chancellor, Kevin Guskowitz has been a long and loyal follower of both Tom Lambeth in his career, but also of this particular lecture. And I hope you will now join me in giving a warm welcome to the 12th Chancellor, Chancellor Kevin Guskowitz.
Thank you, Doug, and welcome everyone. It's great to be here, and it's great to be back for the annual Lambeth Lecture. This lecture gives us the opportunity to hear from public policy leaders who are changing the world every day, and this evening is no exception. Each year, I know the lecture will challenge my own ideas and assumptions, and over the years, the thought-provoking speakers have challenged us and have strengthened our knowledge on critical issues. Thank you to our public policy department and so many in the College of Arts and Sciences, in our classrooms, in our research centers who do this every day. Our UNC Public Policy Department is a national leader in conferring undergraduate degrees in public policy, awarding the highest number of undergraduate public policy degrees nationwide, something we're very proud of. Our speaker tonight, Dr. Mandy Cohen, who served as the Secretary of the North Carolina Department of Health and Human Services from January 2017 until this past December, has been an incredible leader here locally and nationally over the past several years. She served during a very quiet time, right, Mandy? An easy time, we might say, for our state and the nation when it came to public health issues, and I know the feeling. And Dr. Cohen, as I often have said, easy is boring. And we certainly have not been bored over these past few years. And as the leader of UNC-Chapel Hill during the pandemic, your guidance was critical in helping us to plan for our own COVID-19 response, and for that I'm grateful. There's so much that we have to learn from Dr. Cohen, from her leadership, her commitment to excellence, her transparent communication, and dedication to serving the public. And I especially want to encourage our students who are here this evening to engage in this dialogue, in this conversation, ask questions, and learn. Be curious, as I say. That's the beauty of the job that we're in here at the University of North Carolina, Chapel Hill, is we want to engage curious individuals, and that's our faculty, our staff, and most importantly, our students. And finally, I want to also acknowledge Tom Lambeth. You are a leader, someone that I care deeply about, and I know I speak for many here. We're grateful for all that you have done and will continue to do for the University of North Carolina at Chapel Hill, which I know you love. I want to thank Dan Gitterman for your leadership in the Department of Public Policy, a great friend and leader who cares deeply about the issues that we talk about this evening and throughout the year and leading into next year's Lambeth Lecture. He does a great job leading that Department of Public Policy, and I want to thank the Lambeth Lecture Committee for bringing another outstanding leader to our campus. So speaking of great leaders and public servants, I want to welcome to the podium my good friend, Richard Stevens, former North Carolina State Senator and Chair of the UNC-Chapel Hill Board of Trustees, to introduce our speaker this evening.
Throughout the past 2 years of the COVID-19 pandemic, most of us looked for reliable information about the disease as we sought to protect our family and our friends, our jobs, and even just our overall well-being. But in North Carolina, many of us followed the wise counsel of Dr. Mandy Cohen. Hers was the consistent, calm, yet professionally informed voice that we came to rely upon. She really was the face of North Carolina's COVID response. I believe I read that she did over 150 press conferences on this topic. I know I watched many of them myself. Her leadership and the state's response to COVID have been lauded for its focus on equity, on data accountability, and transparent communication. And we all saw that through her many, many presentations. She led also, while doing all that, she led the transition of our Medicaid program in North Carolina, and has been given national recognition for the innovative focus on whole person care and the non-medical drivers of health. 2020, the Raleigh News and Observer named her the Tar Heel of the Year for her significant contributions, and well-deserved at that. Prior to working here in North Carolina, as you may know, she was the Chief Operating Officer and Chief of Staff at the Centers for Medicare and Medicaid Services at the federal level. She's been, for those in the academic world, she's been elected to the National Academy of Medicine and currently serves as an adjunct professor at our own Gilling School of Public Health, and we thank you for that service as well. Graduate of Cornell, she got her medical degree from Yale, master's in public health from Harvard, and trained in internal medicine in Massachusetts General Hospital. She just recently joined a leading primary care enablement company as their executive vice president and will serve as the chief executive officer of the company's new health services unit. We are indeed fortunate to have you with us tonight. Please join me in welcoming Dr. Mandy Cohen for this year's Lambeth Lecture.
Thank you, Richard, for that kind introduction, and Chancellor Guskowitz. It's been a couple of years, and I thank you for your partnership and all of the collaboration over these challenging years. Thank you, Doug, also for bringing me here, and of course, thank you to Tom for the example that you set for all of us across North Carolina of the kind of service we want to give back to the people who are here in our state and beyond. It's an honor to be giving the lecture today. I am shocked anyone wants to hear anything else about COVID. I know we've been over it for so long at this point, but I do appreciate this opportunity to look back and take stock of what has happened, what we've learned, and what we can do as we try to move forward from this. We will and move forward from this. It was actually a very, very hard talk to put together. While it was 2 years of work, which felt like 10, there are so many things that the twists and turns of what the last 2 years have brought that I want to share. Can't do it in 45 minutes. So I'm sure there are things I will leave out. There are more lessons I want to tell you about, and there are certainly a number of ways in which we need to move forward. I'm certainly going to focus on the ones that are closest to my area of expertise in public health and public policy, but there are so many around actually the fundamental scientific investments we need to make and beyond that I hope we will have continued conversations about. But I'm excited to jump in, and so this talk will really be in 3 parts. First, a look back, then a bit of what does that mean and what did we learn from it, and then what do we do going forward. And the reason I want to make sure that we do take the moment to look back is that we know it's been said many times, those who fail to learn from history are doomed to repeat it. And those who are looking at the screen behind me, you may recognize on one side something familiar to us now is the COVID virus. But on the other side, on the left here, is the flu virus. And so I think many of you will remember as we looked back to our history of other infectious diseases to learn the 1918 flu pandemic that crippled the world back then was you saw some of the same exact things that happened in 1918 happen again here in the last 2 years. So we have to make sure that we are learning from this experience so that we don't go through it again. So to start off, it's really important to think about any crisis response as what was our preparation going into it. A bad thing's gonna happen because it's a crisis, right? You have to think about it the same way you think about a hurricane. It's no one's fault. Hurricanes happen. How prepared are you going into that response? And I think North Carolina had a lot of strengths, but COVID threw at us some very, very unique challenges we were not ready for. I do think we had some strengths of having some existing data systems, some flu and communicable disease surveillance systems built over a number of years with a lot of hard work. One of the really clairvoyant things is actually having a consolidated state-level health and human services agency. This is something that predated me, and it doesn't actually exist in that many states across the country. Often you'll see the components of health and human services broken up into many agencies that are direct reports to a governorship. But what I think bringing that together under one umbrella really allowed us in North Carolina to have a lot more collaboration, coordination, and frankly, better execution in our crisis response because they were all under one department, and we were able to leverage resources from all parts of the department in the response effort. Lucky or not, we have been a state that's seen crisis. Hurricanes are something that we have unfortunately gotten used to responding to, and the partnership with emergency management, both at the state and local level, had been pretty extensive. Even between the relationship in my department and emergency management, there were relationships already there that I think were incredibly important to accelerate our response effort. I want to praise the relationships between our major hospital systems. I'm going to come back and talk about this more, but I think it really was a differentiator for North Carolina. Not that we just had great health systems, but that they worked together. These are business competitors that needed to work together, and I saw that every day in North Carolina, and I will say that did not exist in every state. And I also think, as Richard had mentioned in the introduction, the fact that we were focused on some whole person health efforts before we went into a crisis was really helpful. So we had a foundation to work from. But wow, COVID threw at us some unique challenges. This was a new and changing virus. We had really little information at first, and it was the first time I think a lot of us were seeing science play out in real time. And that was hard to watch because we didn't know all the answers at the beginning. And a very smart communications expert said to me, in any crisis communication, you want to get all the information you can first and then decide what to talk about. That is not possible in this crisis. We didn't have all the information, and frankly, we're still learning information 2 years later. It is the first time, I will say, I think in my lifetime, that I've saw the profound resource scarcity that we went through, whether that was the limited number of tests that we have, or the non-existent tests at first, and then the very limited tests, to the limited number of vaccines, the limited treatment. Our society is experiencing resource limitations and scarcity all the time, but this took it to an extreme level, I think, that showed all of the cracks and the worst, unfortunately, sometimes parts of our system. Lack of data was profound, and unfortunately still exists to this day. We're going to talk a lot about data because I think it's one of the most important tools in being able to move forward. And unfortunately, we were going into this crisis with a lack of cohesion and trust. I think what a lot of folks are starting to understand about crisis response is that trust is really, really hard to build during a crisis. And so you need to have that trust and cohesion going into the crisis. We definitely saw countries who had a more cohesive and trusting scores, as you look at certain societies, that they actually had a much better response. Even if they had less resources, less data, less everything, that cohesion really mattered. We also had an underinvestment in public health, and I would say that was doubled here in North Carolina. In 2014, there was a study done just to understand sort of an apples to apples comparison of public health investment state to state. And in 2014, North Carolina ranked 47th out of 50 in per capita public health investment. So we weren't leading the pack in getting ahead and investing in a public health system, and I think that showed in some of our challenges as we tried to build up that response effort. And lastly, we went into the crisis with a less healthy population. We are an older population here in North Carolina. We are unfortunately have more chronic diseases, and we haven't taken certain steps to expand access to care, like expanding Medicaid, which I've been very outspoken that we needed to do before, and we absolutely need to do going forward. So this was the scene that was set for COVID, and then I've tried to figure out one way to bring one slide to look at these past 2 years. So here's my attempt to do that in one picture. So the top is the number of cases of COVID over the last 2 years. The bottom is the number of COVID deaths. Obviously, these are different scales. The top number of cases you'll see in a day goes all the way up to 40,000. Deaths in a day goes to 120. But you can see those three large, really the peaks over these 2 years. The first peak was what I'd call COVID, the original. It was the winter wave in between 2020 to 2021. It was before we had vaccines that were available. Then the next peak there was the Delta wave, and then the last was Omicron. And what you can see here as you put together the cases and the deaths, that the vaccines definitely did protect us as we went forward, but we did see that with a lot of cases, even with Omicron in this last wave, we did see a lot, unfortunately, of folks succumb to this virus that is constantly changing. What I want to remember and think back to, because as we think about lessons learned, is what did it feel like 2 years ago? I was thinking about that in particular on St. Patrick's Day, because I remember it specifically. It was the day that we went to a stay-at-home order back in 2020. And back then, you're going to see, if you look at the chart, you're like, we didn't have a lot of cases. But if we remember all the way back to then, we also had such limited tools, such limited understanding of this virus. I remember those times where we were frantically scouring the earth for protective equipment for our hospitals. We literally could not give our nurses N95s to protect themselves at the hospital. We absolutely didn't have any tests, so we didn't know who had what. It was a frightening time. And when you had that limited information and you needed to think about protecting health as we figured that out, we had to use more drastic measures like stay at home at that period of time. But luckily, we learned quickly over time how to respond. We learned more about what this virus was, who it affected more, how we can protect people from getting it, and we got better at knowing what are the settings and scenarios which would cause more spread of the virus. So we were able to sort of start to selectively say, this is safer to do, wear a mask, wait 6 feet apart and wash your hands, and we started to have a campaign around the 3 Ws. And as we thought about trying to protect folks, not overwhelm our health system until we got the vaccine. And I'll say, what an achievement of the scientific community, getting us a vaccine in less than a year. I think many of you know that the earliest we got a vaccine prior to that was a 4-year cycle. So not only were we able to have a vaccine that was approved, but it was also mass-produced. It's incredible, and I don't think that we recognize as much the incredible achievement and collaboration, some of which came from this university and others in North Carolina, that allowed us to get from early January of 2020 to a vaccine in many, many arms by the end of that year. It's just incredible. I think we did some hard work to, like I said, maintain our hospital capacity and make sure that we were not overwhelming it, to make sure folks were not dying. But you can see we struggled with folks and spread throughout that time until we really had vaccines. Thought we were doing good, and we were really proud going into June, particularly of 2021, and then the virus changed. And this is a big lesson we'll talk about learning, is making sure we have the humility in our work to recognize that you're not going to have all the answers at all moments, and things can change. And that was what happened with the Delta virus. And the need to do more. Obviously, we also needed to move forward in getting vaccinations for those under the age of 18 and our children. So a lot of work throughout this, and just hard to, I wanted to share so many details in this space, but I really want to talk about moving forward. But before I do that, just a bit on how do I think, if I look back, how do I think North Carolina fared overall? First and foremost, I'm really proud that we never overwhelmed our health system capacity anywhere in the state. And that is not something that most states can say. I don't think we ever saw the colossal implosion of the health system like New York saw right at the beginning, but we absolutely saw pockets of health systems just be completely overwhelmed and need to call for help. We never had that here in North Carolina. Multiple times we were sending ventilators to South Carolina. We luckily never needed to do that, and we're really always able to stay on the helping end as opposed to needing to call in help, and I think that's pretty remarkable in and of itself. If you look at our numbers, though, I'd say we were a little bit better than average. If I look at the end of 21, we ranked 31st for cases and 36 for deaths. This is the one you want to be closer to 50 is better. So 31, we're better than average, 36, pretty good. So what that tells me is we had viral spread here, but we actually were better at really being a bit more targeted, if you will, in protecting those who are most likely to be ill. And that was part of our strategy. If you look overall in the Southeast, we had the lowest death rate in the Southeast, something I am very proud of. And again, as we thought about that, really being focused in our efforts to those who are at highest risk, we were top in the nation for vaccinating those over 65. So in North Carolina, 95% of those over 65 are fully vaccinated. That means gotten at least 2 doses of Pfizer and Moderna, or 1 of J&J. That's a really incredible achievement. So our highest risk folks, really, we did a good job of getting them vaccinated. The other thing that I'm incredibly proud of is that we did all of our response work thinking about equity. And we had among the lowest in the nation for any equity gaps. And so what that means is, particularly if you look at our vaccination rates for our Hispanic community, after a lot of partnership and a lot of work, we actually were vaccinating in our Hispanic community at a higher rate than even in the white community. And then for our Black community, we were about even, and sometimes even higher in certain age groups. So that is something we did not see across the country, and again, I think was unique to North Carolina's response effort and prioritizing equity. And at the same time that we were always thinking about our stats related to public health, we had to, at the same time, hold the impact of this virus on the economy, on people's livelihoods. I certainly saw that every day in the governor's leadership, holding both public health and economic health. And an indicator for that, in addition, was that we had the lowest job loss in the nation during the COVID crisis. So really trying to both, think about the competing interests and the tensions that were always there. And I think we did a good job of trying to find that middle ground. I think the other things that I'm incredibly proud of are some really, really important partnerships that I'll come back to, some data systems that we built that were invaluable, and the transparency that we were able to provide with dashboards, but also the data and dashboards allowed us to really target our efforts in important ways. And again, we were lauded, which I'm very proud of, for our equity and our race and ethnicity data. And we often focus on did folks get tests? Did folks get vaccines? But we know that there was so much of a devastating impact of COVID beyond just access to medical care. We know that folks' lives were turned upside down, and we at the department, again, because we were Health and Human Services, were able to put together some really incredible programs to help people not just get access to a test, but really make sure that they could thrive even though we were in a crisis. We put together, for example, a COVID support services program where we helped folks who needed to isolate at home, and if they worked at a job where they wouldn't get paid if they don't show up, we were able to do things like wage replacement, help paying for rent, food delivery, transportation. And it has been recognized as a model as we go forward in crisis response in the future. I think that's something we actually really learned well in our hurricane response and very much put it to work here for COVID. This is what my year looked like. It was a lot of what you saw was the podium, a lot of talking at the podium, but what it really was marshaling incredible people across this state that I'm so proud of. Whether it was community health workers who were giving you the thumbs up there, who were from our Latino community, who really reached out to make sure that we were building trust around vaccinations, or our doctors in our emergency rooms who were absolutely on the front lines every day, or our military here in North Carolina, that's an airwoman who was at one of our vaccination sites, or the many nurses doing work. These are the folks that I was thinking about every day, in addition to the many millions of North Carolinians who needed good information and wanted to understand where we were going next. So it was a hard 2 years, but I look back at these pictures and remember the incredible work of North Carolinians across the state and what an incredible team effort this was. Okay, so I want to get to lessons learned, the meat of the talk. I think a lot of us remember the last 2 years. It hasn't been that far. So what did I personally learn? And again, it was really hard to just come up with a few here in terms of lessons. So first, I think there's incredible power in a unifying vision and purpose. And this is where, as we think about public policy, and particularly leadership of those who are making those policies, having a clear way to articulate what we're trying to do and why is so important. I go back to that scientific achievement about the vaccines. Yes, the scientists made that vaccine, but it was also an achievement in manufacturing. We had never manufactured at that level, that scale, that pace before in any time in history. And that unifying vision and purpose, I think, allowed us to bring all of those kinds of resources together for that kind of achievement. And I saw it every day in multiple ways. And I think I've learned the most about leadership and communication through this crisis. And I will say we could not have been more lucky to have the governor that we did. I was so grateful to that he and I were partners in as we moved through this crisis. He's an incredible leader, and that very much focused on the ideals of transparency, simplicity, and humility at all points. Transparency, man, 150 press conferences. I don't think we could have talked more and answered more questions. And I never thought I would be in front of a camera talking about graphs and look, this line's going up and this line's going down and red and green, and try to help folks see what we were seeing. Understand when we had to make a hard decision why we were doing it, what information we were looking at, and explain what we were doing. We tried to do it in the best way we could around being simple and repetitive. I'm really proud of the 3 W's campaign. I know it was working because people stopped me in Target all the time and said, "You're the 3 W's lady," and that's right, I was. But it means our campaign was working. Folks knew about the 3 simple things that they needed to do, and I said it a million times, and that was intentional. And most importantly, the humility to maintain trust. I think there was a lot of missteps at times where there was We wanted to project an air of certainty when this virus did not allow us to do that. I think we always tried to give as much information as we could, but trying to put it in a context of saying, this is what we know right now, today. So when folks say, well, would you have done this differently or that differently? You can always Monday morning quarterback a crisis, but in that moment, you have the information you have to make hard decisions. And I feel like we really worked hard to put all of those decisions, why we were doing it, put it into context to maintain trust. And I think that was really important for us to counteract a lot of misinformation that was out there. And I get it. Everyone on Twitter turned into an armchair epidemiologist. All of a sudden, people who'd never heard of epidemiology were already amazingly experts in it. And so there wasn't a lot of great information sometimes, so we really wanted to make sure we were putting out as much good information as possible. And again, I'll go back to the governor here, where I learned so much from. He is the most amazing listener of any political official I've ever worked for. People often think of communication as what's said at the podium, but so much of what leading is about is listening. Listening to your team, listening to the different stakeholders, and he is the best listener. I hope that I can emulate that as I go forward into my career, and as we go to okay, if I learned this lesson, what do we do about it? I need help from the School of Public, the Department of Public Policy to tell me what policy lever to pull to make people good listeners, because it's really important. We need it. The other part of this that's incredibly important was the need to have centralized public health decision-making ability and authority. And if you're going to give folks that authority, it definitely has to come with accountability, but you do need that centralized decision-making ability. I'll give you the two examples of where it went really wrong and then where I thought it went right. These are both at the federal level. First, when we first got into this crisis, there was really an absence of federal coordination, particularly around the supply chain. We were all, the states and localities, hospitals, we were competing against each other to buy ventilators, to buy N95 masks, to buy gowns, and it really was a mess. It drove up the price. We didn't get the things that we needed in the right time, and we had stockpiles in places that were very resourced, and we had empty shelves in places that didn't know who to call and how to call. And so that worked badly. That did not go well. But when we got to vaccine efforts, as you well know, the federal government made all the purchases for the entire country. There were times where multiple states said, can I buy more? Can I buy differently? And no, we really stayed coordinated to let the centralized federal government both purchase the vaccine, create the distribution formula, and get them to each of the states. Then it was our job to then allocate that out beyond. I think that was, while hard, and one of the hardest things I have ever had to do as a leader is really think through how did we get those millions of vaccines in a prioritized way out to our community. I think it was so important. If we had had the every man for himself kind of mentality that we had at the beginning, I think we would still not have folks vaccinated today in the same way. So I really think that this is critical as we go forward. Obviously, if you're going to centralize authority, though, it has to come with accountability. You got to be doing a good job if you want that. We want that authority, and we have to put the guardrails on it. Another important lesson, I certainly, as I mentioned earlier, that I took away was the critical nature of coordinating our public health infrastructure with our traditional healthcare infrastructure, our hospitals, our clinics, coordinating with our local public health departments. If we expected public health to respond alone, we would have never made it. This had to be an all-hands-on-deck effort, but we also needed to know who was doing what. We needed role clarity, we needed to know who was responsible for what, and we built that as we went here, but I think we have a lot of lessons learned that I'll get into about how we need to coordinate across the system a lot better. And again, I think one of the reasons North Carolina fared well was because we were able to do this well. Data, data, data. Data is the oxygen that powers this response. We are incredibly diligent in gathering information, data, intelligence when it comes to national security. That is something we pride ourselves on, and having incredible data and insights so that we can protect this country. We have to see data insights in the public health and healthcare space as important for us to have those insights going forward. It is national security. I'm going to talk about tactically what does that mean going forward, but without data, we are blind in a response effort. I think we got much better, more quickly over time, but we need to make sure we're building a place where we have good data. We can't just, data is only as good as what you will get in and your ability to put it together to tell you what's going on. But this is absolutely critical for a response going forward. And then on health equity, I was mentioning that in our response effort, we really put equity at the center. Again, another way in which the governor's leadership really was powerful here. But you can't just say, I'm interested in health equity. It takes prioritization and work every single day. You can't put one person in charge of health equity off to the side on your team. The leader of the organization needs to own it from the top every day, all the time. And that is hard because there's a lot going on in a crisis, and it's really, really hard to make sure that you just don't fall back into old patterns and skip over what efforts are needed to make sure you're really building on equity. And again, this is where data comes in. You can't solve problems you don't see. And the data really helps you see where are certain communities getting less access to a test or a vaccine that we need to deploy extra resources. But it is constant effort, and it needs to start at the top. The last is that whole person care matters. I think if we were only focused on tests, as I said, or only focused on vaccines, we would do well, but we would miss such a large component of what makes up someone's wellness and being healthy, and making sure that we're creating an infrastructure both going into crisis, but during a crisis that thinks about whole person care, whether that's behavioral health, access to food, stable housing, as well as access to medical care. All right, so those are my lessons learned. Those are conceptual, philosophic points. I want to get a little tactical now for our public policy students in particular about what does that translate into in terms of public policy. You're going to see, like I said, I'm not going to touch on what does that mean in terms of NIH funding and the basic scientific research, but really what are those infrastructure investments we need going forward. So here are the main components of what my thinking is at this point. Again, I want to caveat, my thinking continues to evolve on this topic as I get more distance and more learnings from this. But first and foremost, we need a data infrastructure that can power a response going forward. Some have conjectured that if we had better data, not just here in the United States, but across the world, that we could have reacted differently in a different period of time, and maybe we're not in a 2-year crisis. We're looking at something that is shorter. Again, hindsight is 20/20. We need data systems to help fuel this. But the problem is you can't just build pipes to say, oh, you just send me data over here and that'll work. You need the authority to say you must. We got lucky here in North Carolina that we were able to do a lot of data sharing because of relationships that we'd built over time, not because of authorities that existed. And you can't rely on that in a crisis. The authorities have to be there. And I get it. Data is power. Data means leverage for a business, particularly in the healthcare space. Data is coveted to make sure that you are winning in your space. So we have to think about this thoughtfully, but we have to get to a place where data, and particularly clinical data, and what I mean by that, we need to know what's happening in emergency rooms, right? If people are showing up with a collection of symptoms, we need to be able to understand that, identify it, investigate it quickly. And so there's more we need to do, and it has to be at the person level. We also need to be able to identify that data in a way that John Smith over here is different from John Smith over there, and we know who those folks are, and we really need to think about unique patient identifiers so that we can track people over time, again, in service of making sure we know what is happening and be able to respond to efforts. The So that's data. I could talk about data for a long time. I love data, but it's really, really important. The other parts is thinking about the core public health structure and authority here as well. I think we have a lot of work to do, and folks are doing it. I thank the Institute of Medicine in North Carolina who's doing this work to really think about what is core for public health, what are those core functions, what are the things that they take on because they just need the funding temporarily versus what do we need them to be focused on, and we need to resource it appropriately. What's the appropriate size? I will say we have 85 local health departments for a state of 10.5 million people. Just to compare, California has 53 for a state that's 10 times our size, right? So there is, I don't know if theirs is right, but I'll tell you that it probably feels like we having 85 for 10.5 million people is probably we haven't right-sized things enough in order to create a structure that allows us to be sustainable and well-funded over time. I also think we have to think about workforce. We went into the crisis with so many vacancies, and you can't fill those vacancies in a crisis. The thing that dried up for me immediately was talent. And trying to figure out how we got talent into our state to build data systems or to build a public health response effort was really, really challenging. So we have to think, and this is where universities and others really need to get in the recovery effort with us, thinking about workforce pipeline, training, and deployment. Again, I'm bringing up the topic of the roles and responsibilities for our healthcare system. We have a lot of players in various parts of our healthcare system. We spend a lot of money from the government space on laboratories, on health systems, with our primary care infrastructure, but we are not clear about what our expectations are with those entities of what we need from them in a crisis. And we need to make sure that we are clear what their responsibilities are, that when you get funding, for example, from the federal government, millions and millions and millions of dollars, there should be certain requirements that you need to do in order to be ready to respond to a crisis. Some of those may be data sharing, some of those may be workforce training and tabletop exercises so that a nurse who might work in an outpatient setting could rapidly be redeployed to work in an ICU if needed. Those kinds of things, but we have to get really specific about what we need and what we expect for the resources and accountability that we need. Some actions beyond public health really speak to what we've been through in terms of an emergency response. I think those in public policy space know that our emergency powers or emergency authorities were really created with a hurricane in mind or a weather event, something temporary in mind. They absolutely were not thinking of a prolonged public health emergency. But here we are, we've learned lessons, and so I do think that we have to rethink what is both the decision-making structures and the authorities that we need. I think when I mentioned, I think one of our strengths here in North Carolina was the umbrella of Health and Human Services. I saw that break down at the federal level, where there were a lot of very well-intentioned folks doing hard work, not in coordination with each other. And it was really hard to pull all those threads together. And when the federal government was disorganized, it was really hard for the states to react. And if the state is disorganized, it's hard for the locals to react. So I think that alignment is really important. And we really need to be modernizing our emergency authorities to reflect what a duration of a public health emergency would be. Everything from needing flexibilities around procurement to the fact that we had very crude tools by which to protect public health. We basically had to throw you in jail if you violated something. And we all know that there are ranges of ways in which folks were not following along on some of the mandates and other requirements. None of, that jail time felt extreme. And we didn't have other tools to use. So I think we really need to think through and look at some other states that I think had more of a menu or an array of tools that could be used that would step down from everything is a criminal penalty when thinking about a public health emergency. I think that was a little too extreme of a blunt tool for us to use. The other piece is that you have to think about making us stronger overall as we think about going into the next emergency. We have to invest in health equity and whole person care. In North Carolina, absolutely 100% must expand Medicaid. We have to at least give folks access to preventative care right now. We want folks to be as healthy as they can going into any one of these crises. And so there's tons of public policy here that I could go through, but I don't want to divorce that from recovery efforts around COVID. It has to be important. And then there's some non-policy things, but are the actual real important things that we have to do together collectively, because there's no policy lever to pull to tell folks to be a good listener, for example, as I said with the governor. But how do we build and maintain those critical relationships in non-crisis time? Like I said, relationships were so key, certainly a major takeaway from me. I want to make sure that we are embedding that in how we prepare for the next crisis. It's not a policy, but it is definitely something that we all need to invest in. And the best that I could think of related to leadership and communications is, I will just tell you, I felt like there was very little scientific rigor in this space. So when I went to look and said, how should I do this? Right? Where is the academic paper that's telling me what is the best way to communicate this, or to think about behavior change? There were some, and we sought it out, and we tried to put it to work. But I think we need a lot more rigorous research and training in leadership, healthcare, particularly focused crisis leadership, communication, and behavior change. Again, another place where academia can really play a large role going forward. Okay, that was a lot, I recognize. But those are a little look back, a bit of lessons learned, and then some tactical things that I think we can all do right now. If you are having trouble sleeping, there is a very long paper that we put together that documents a lot of it. I just happened to put the link in here that we documented through the end of December, my tenure at the Department of Health and Human Services. And I think I'm so proud of the work. I'm so grateful to my team at the department, who just went over and beyond every single day and did more than I could have ever hoped that they did. They did it with such a service mentality, and I'm so grateful that I got to work alongside them. Again, I've already praised the governor and his team, who are also incredible, but it was everyone from Chancellor Guskiewicz to every leaders in the General Assembly. It was really heartwarming to, folks look at Twitter and think everyone's fighting with each other, and that is not the reality of what certainly I experienced when I needed to pick up the phone and said, I need something. 99 times out of 100, and there were that many calls, folks were like, how can I help? And that was what I was really grateful for in North Carolina, and I think one of the things that we have to think about making sure that we can maintain as we think about crisis response going forward. Thank you.